Welcome back to the deep dive. Today we're looking at an element that really underpins a massive part of modern medicine.
It's a huge part.
And it's a bit of a paradox. I mean, in its elemental form, this stuff is just incredibly reactive, often toxic.
Right.
But when you sort of domesticate it in the lab, you weave it into a molecule, it just becomes this incredible workhorse.
In everything, yeah.
We're talking about fluorine.
It really is a Renaissance story. You know, most people hear fluorine and they think, what, toothpaste?
Toothpaste, maybe high school chemistry.
Some angry yellow gas. But the book we're breaking down today, Fluorine and Health, it makes the case that modern medicine would look, well, pretty unrecognizable without it.
It's the silent partner in the OR, really. And for all of you listening today, whether you're a med student prepping for boards or a professional just wanting to get the mechanism, we're treating this like a high-yield board review. We have three main targets: imaging, materials, and pharmaceuticals.
Yeah, that's the plan. We'll cover how fluorine-18 completely changed PE scans, then how fluoropolymers are used in things like grafts, and finally, why medicinal chemists are, like, obsessed with the carbon-fluorine bond.
Okay, so let's start with diagnostics, molecular imaging, PE scans.
Positron emission tomography.
We all know it's the gold standard for oncology, for tracking metastasis. But the whole system hinges on the instability of an isotope.
That's the core of it. You need something that emits positrons. The positron hits an electron and you get this annihilation event.
A puff of gamma rays.
A puff of gamma rays that the scanner sees. The problem has always been logistics. I mean, the really biologically relevant isotopes like carbon-11 or oxygen-15.
They decay way too fast. Carbon-11 is what, 20 minutes?
About 20 minutes.
Yeah.
And oxygen-15 is just 2. You'd basically need a cyclotron in the hospital basement to make it work.
Which is just not going to happen for most places.
No. And this is where fluorine-18 or 18 just saves the day. It's the Goldilocks isotope. Its half-life is around 110 minutes.
So you have a window?
You have a real logistical window.
Yeah.
You can make the tracer at a central facility, put it on a truck, and get it to a satellite clinic while it's still, hot enough to use.
So the supply chain really dictates the chemistry, but we're not injecting raw fluorine, obviously. We're using FDG.
Fluorodeoxyglucose, yeah, the absolute workhorse of PE imaging.
And the mechanism it's just brilliant. It's a trick.
It is. We call it metabolic trapping. See, FDG looks almost exactly like glucose to a cell.
It's dinner time.
It's dinner time. You inject it, and it gets pulled into the cells by the same glucose transporters, the GLUTs.
And of course, tumors are the hungriest cells around. The Warburg effect.
They're just guzzling glucose, so they take up a huge amount of this FDG.
Okay, so it's inside the cell. Then what?
Once inside, the first enzyme in glycolysis, hexokinase, it phosphorylates it, puts a phosphate tag on it.
Just like it would with regular glucose.
Exactly. But here's where the trap springs. The next enzyme is supposed to work on a hydroxyl group at the carbon-2 position.
But in FDG.
We've swapped that hydroxyl for the fluorine-18 atom.
And that's like a doorstop. The whole process just halts.
It hits a wall. The enzyme can't process it. But, and this is the key, the cell can't kick it out either because of that phosphate tag.
So it's trapped.
It's trapped. It just accumulates inside the tumor cell, emitting positrons. The tumor basically eats a meal, can't digest, and ends up glowing on the scan.
The Trojan horse. Now, the book mentioned this isn't just for cancer. There was this really fascinating neurology case study on Alzheimer's with twins.
Oh, that was a powerful image. Monozygotic twins. Identical genetics. One has Alzheimer's, the other is healthy.
And on the PET scan.
The difference was just stark. In the healthy twin, you see this brain lit up with activity-high glucose metabolism.
And in the affected twin.
You saw these dark, cold patches, specifically in the temporoparietal areas.
Because the neurons were basically dormant.
Or dying. They weren't metabolizing, so they stopped taking up glucose and they stopped taking up the FDG. It lets you see the functional problem long before you see the brain actually shrink on a CT.
So before we move on, a quick nod to MRI. We usually image hydrogen, right? Water. But there's a thing called fluorine-19 MRI.
Yeah, it's an emerging field. The big advantage is the signal-to-noise ratio. Your body is full of water, so there's a ton of background signal in a normal MRI.
A lot of noise.
A lot of noise. But your body has basically zero natural fluorine. It's a completely black canvas. So if you inject a fluorinated agent, the only signal you see is from that agent. It's perfect.
Okay, let's switch gears. We've seen how fluorine helps us see. Now, how does it help us build part 2, biomedical materials?
Right. And here, we stop caring about radioactivity and start focusing on its It's extreme electronegativity.
And I think the most common example is in vascular surgery. Grafts,
Grafts, yeah. If you're replacing a piece of an artery, you're probably using EPTFE.
which is basically Teflon.
It is Teflon.
Yeah.
But there's a very good reason it's in your artery. Fluorine is the most electronegative element there is. It holds onto its electrons so tightly.
Which makes the carbon-fluorine bond incredibly stable.
And very low energy, which makes the surface hydrophobic. It repels water.
And in the bloodstream, repelling water means it's anti-clotting.
Exactly. Antithrombogenic. Blood is just this soup of proteins and platelets looking for a surface to stick to and start a clot. But the fluorinated surface has such low surface energy, they can't get a grip.
They just slide right
They
past.
slide right past. It's that chemical inertness that gives these grafts such amazing clinical longevity.
Okay, now for the application I thought was just wild. Ophthalmology. Using heavy liquids for retinal detachment.
This is such a cool use of pure physics. When a retina detaches, it peels off the back of the eye.
Like wallpaper.
Yeah, like wallpaper. And the surgeon needs a way to gently press it back into place so they can tack it down with a laser.
And you can't just poke it.
No. So they inject these perfluorocarbons. They're called heavy liquids because they have a really high specific gravity. They're much denser than the water or vitreous humor inside the eye.
So it's not about chemistry, it's about density.
It's purely mechanical. You inject the liquid, it's heavier so it sinks to the back of the eye.
Yeah.
As it sinks, it pushes the water up and out of the way and physically unrolls the retina.
It literally irons the retina flat against the back of the eye.
It acts as a liquid tamponade, using gravity as the tool. And because those CF bonds are so stable, the liquid is totally inert. It doesn't cause any toxic reaction while it's sitting there.
Amazing. Okay, let's get to the hard tissues. Dentistry. We all know fluoride in toothpaste strengthens teeth, but that's always felt a bit vague.
It's a bit of a hand wave, yeah. The chemistry is really about geometry.
Okay.
So your tooth enamel is made of a crystal called hydroxyapatite, but it has a weak spot. Inside its crystal lattice, there's a hydroxyl ion, an OH group.
And that's where acid attacks.
That's where acid from bacteria attacks. It dissolves that bond, and that's the start of a cavity.
Yeah, then fluoride comes in.
Right? And the fluoride ion swaps places with that hydroxyl ion. But here's the crucial part. The fluoride ion is smaller. It has a tighter ionic radius.
So it fits better. It packs the crystal tighter.
It fits into the lattice perfectly, snugly. It literally densifies the whole structure. The new mineral is called fluorapatite, and it's just thermodynamically more stable.
So you're fundamentally changing the crystal structure of your tooth to be more acid resistant.
Exactly. The acid just can't dissolve it as easily. It's a brilliant piece of chemistry.
All right, time for the main event, part 3, pharmaceuticals. The book had this incredible statistic. Something like 20 or 25% of all new drugs have fluorine in them.
It's a huge number, especially when you consider fluorine is almost non-existent in natural biology.
So what's going on? Why do medicinal chemists love it so much?
Well, they use it to solve very specific problems, and the biggest one is metabolic stability. We could call it the Teflon effect on a molecular scale.
Okay, explain that.
The liver's job is to get rid of foreign things. It has these enzymes, cytochrome P450s, that love to oxidize carbon-hydrogen bonds. CH bonds are an easy target.
So a drug with an exposed CH bond gets chewed up by the liver before it has a chance to work.
All the time. So what chemists do is they find that soft spot, that specific carbon atom where the metabolism is happening, and they just replace the hydrogen with a fluorine.
And why does that work?
Bond strength.
Okay.
Simple as that. The carbon-fluorine bond is the strongest single bond to carbon in all of organic chemistry.
So the enzyme just can't break it.
It can't. It doesn't have the energy. You've blocked that site of metabolism completely, and suddenly your drug has a much longer half-life.
A once-a-day pill instead of one every 4 hours.
That's the goal.
But it's not just about staying in the body. It's about getting to the right place, like the brain.
That's the second pillar, lipophilicity. To get a drug to treat, say, depression, it has to get past the blood-brain barrier.
Which is a lipid membrane. It likes fatty things.
It loves fatty, nonpolar molecules, and adding fluorine, especially a whole trifluoromethyl group, a NECN-CF3, makes a molecule much more fat-soluble.
So it's like greasing the molecule to help it slip through the barrier.
That's a great analogy. It just helps it slide right through. It's why you see that CF3 group on so many CNS drugs like fluoxetine, Prozac.
I want to focus on one specific mechanism from the book, 5-fluorouracil. 5-FU.
Oh, a classic. A suicide inhibitor.
It's another Trojan horse.
Right, the perfect Trojan horse. It looks just like uracil, which is a building block for DNA, and cancer cells, which are dividing like crazy, are desperate for uracil.
So they grab the 5-FU instead.
They grab it. Now, normally, an enzyme called thymidylate synthase comes along and converts uracil into thymine. And to do that, it has to pluck a hydrogen atom off the number 5 position on the ring.
But on 5-FU, there is no hydrogen there.
There's a fluorine. And the enzyme binds, it tries to pull off a proton that isn't there, and because that CF bond is so strong and fluorine is so electronegative, it gets stuck.
It doesn't just block the enzyme, it breaks it permanently.
It forms a covalent bond. The enzyme catalyzes its own destruction. That's suicide inhibition. And the cancer cell, it runs out of thymine, it can't make new DNA, and it dies.
That is just...
Yeah.
It's brutal and elegant. Let's do one more example, the corticosteroids. This goes way back to the 50s.
Fried's discovery. This was the discovery that really put fluorine on the map for drug designers. They were trying to make cortisol better.
Sure.
And Fried found that adding a single fluorine atom at the 9-alpha position of the steroid, it increased the anti-inflammatory power by 11 times.
An order of magnitude from one atom.
Yeah. But there was a huge catch. It also cranked up the mineralocorticoid activity, the salt retention, to really dangerous levels.
So you'd have no inflammation, but you'd be retaining fluid and your blood pressure would be through the roof.
Exactly. It taught chemists that fluorine is a potent tool, but you have to balance it. They had to go back and add other groups to dial down the salt retention while keeping the anti-inflammatory effect. That work gave us modern steroids like dexamethasone.
Okay. We've gone through imaging, materials, and pharmacology. Let's try to put it all together.
It's a little clinical synthesis. I like it.
All right, here's a scenario for you. You're a medicinal chemist. You have a new CNS drug candidate, but it's got two big problems.
Okay.
One, the liver's metabolizing it way too fast, right, at the paraposition of a ring. And two, it's not crossing the blood-brain barrier well enough. It's too polar.
So it's being destroyed before it works, and it can't get to the target anyway. A classic double failure.
Based on everything we've talked about, what single chemical change could solve both problems at once?
Okay, so you need to address stability and lipophilicity.
What's the move?
You'd put a trifluoromethyl group, a NAGA-CF3, right at that pair position, or even just a single fluorine atom.
And walk us through why that's the double whammy solution.
Well, first, by putting that super strong CF bond right at the site of metabolic attack, you block the liver enzyme. Stability problem solved.
Right.
And second, that very same CF3 group dramatically increases the molecule's lipophilicity. It makes it greasy enough to slip right through the blood-brain barrier.
One atom, two solutions. That's the elegance of it.
It really is. And it brings us right back to that paradox we started with. I mean, fluorine in nature is often a poison. Fluoroacetic acid is deadly.
But with synthetic chemistry, we've tamed it.
We've tamed it. We use its instability for imaging, its incredible inertness for materials, and its bond strength for drugs. It's biology mostly ignored fluorine.
Too difficult to work with.
The chemistry is just too high energy for most enzymes. It took human ingenuity to unlock its potential.
It's the power tool that evolution left in the box.
That's a perfect way to put it.
So next time you write a prescription for fluoxetine, or order a PET scan, or even just brush your teeth, think about the incredible work being done by that one little halogen.
It's small, it's angry, and it's absolutely indispensable.
That's our deep dive into the medical power of fluorine. Thanks for listening. We'll see you in the next one.